Welcome to the deep dive. Today we're tackling Venous Thoracic Outlet Syndrome, or VTOS for short.
That's right.
Think of it as a kind of traffic jam, maybe, in the big veins running from your arm through your upper chest, the subclavian and axillary veins specifically.
Yeah, exactly. They get squeezed in that tight spot we call the thoracic outlet.
Right.
And that compression can lead to problems like blood clots or just significant narrowing that really messes with blood flow.
Okay, so to really get into this, we're drawing on some solid material today, chapters from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition, focusing right on VTOS.
It's the go-to text for a lot of this.
So our mission really is to unpack what VTOS is, who tends to get it, how doctors figure it out, and what the treatment options look like. We want to give you a really clear picture.
That's good.
All right, so digging in. Fundamentally, VTOS often boils down to a mechanical issue, doesn't it? Something's literally squeezing that vein.
It really is. And, it's not something brand new. People have been noticing this for a while.
Oh, yeah.
Yeah, back in 1875, a physician named Padgett described patients with sudden arm swelling and pain. He initially thought maybe it was vasospasm.
Ah, okay, like the vessel itself clamping down.
Right. But then, not long after, in 1884, von Schroeder connected that kind of acute arm pain and swelling directly to actual blood clots, thrombosis in the subclavian and axillary veins.
And that's where the name comes from, Padgett-von Schroeder syndrome.
Well, the term itself came a bit later, really popularized after a big review by Hughes. But yeah, that's the connection.
Got it.
And it's also known as effort thrombosis, which I think is quite descriptive.
Effort thrombosis. Why is that?
Because you often see it in young, healthy, active folks, people who use their arms and shoulders a lot, repetitively. Think athletes or certain jobs.
Right. That makes sense. So our main focus then is what's called primary subclavian axillary vein thrombosis. That's the core of VTOS.
Exactly. And it's worth noting, these upper extremity DVTs, they only make up about maybe 9% of all diagnosed deep vein thrombosis.
So less common than leg clots, but still significant.
Definitely. And in primary VTOS, the problem really starts with repeated sort of microtrauma to the subclavian vein, right where it passes through the costoclavicular space.
Okay, break that down, costoclavicular space.
Yeah, think of that narrow gap between your collarbone, the clavicle, and your very top rib, the first rib. It's the most forward and central part of the thoracic outlet.
And that's where the squeeze happens.
That's the pinch point.
So what's doing the squeezing in there? What structures?
It's a few key players. You've got the first rib itself, the clavicle or collarbone, and associated with that are the subclavius muscle, which runs under the clavicle, and a band of tissue called the costocoracoid ligament.
Okay.
And then you also have the anterior scalene muscle coming down from the neck, attaching near there, and sometimes a little bony bump called the scalene tubercle on the first rib.
Wow, it sounds crowded in there.
It really is.
Yeah.
And that repeated compression, it can set off this kind of vicious cycle. Well, you get some inflammation in the vein wall from the trauma. Then maybe it settles down. But over time, this cycle leads to scarring around the vein that's perivenous fibrosis.
Okay, makes it less flexible.
Exactly. And you also get damage to the inside lining of the vein, the endothelium. Put that together, the stiffness, the damage, maybe slower blood flow because of the narrowing, and boom, you're set up for a clot.
Now, you'd think there'd always be some obvious anatomical reason, but the reading suggests that's not always the case.
That's true. Sometimes VTOS happens without a really obvious anatomical problem you can pinpoint easily beforehand. But when surgeons actually go in, they often do find subtle variations.
Like what kind of variation?
It could be soft tissue things like the anterior scalene muscle being unusually bulky or the subclavius tendon being tight, maybe even extra little muscles like the scalenus minimus. Or it could be bony things like the shape or angle of the clavicle of the first rib. Even the costocoracoid ligament can sometimes be abnormal.
What about cervical ribs, those extra ribs some people have in their neck? I know they're linked to other types of TOS.
Yeah, they're more strongly linked to arterial TOS. Something like 68% of arterial cases might involve a cervical rib. For VTOS, it's less common, but they can be a factor. The sources say maybe 2 to 9.4% of VTOS cases.
Okay.
And don't forget about trauma. If someone breaks their collarbone or first rib, the healing process, the callus formation, or maybe a pseudoarthrosis, a false joint, that can definitely encroach on the space and compress the vein later on.
Right. Now, here's something I found really fascinating in the material. It says that in people with VTOS on one side, it's actually common to see narrowing in the vein on the other, unaffected side during arm movement.
Yeah, that's quite striking, isn't it? We're talking maybe 56 to 80% show some dynamic narrowing on the contralateral side.
But actual clots on both sides are rare, only 2 to 15%.
Exactly. So just having that anatomical potential for compression doesn't automatically mean you're going to get a clot. There's more to it.
Interesting. It highlights that maybe there are different degrees of this, different responses.
Absolutely. And to help sort this out, the Society for Vascular Surgery actually developed guidelines to classify these venous thoracic outlet issues.
Okay, so how do they break it down?
Well, the classic VTOS is when the main compression is right at that costoclavicular junction, rib and collarbone.
Right, the spot we keep talking about.
But if the compression is happening further out, sort of under the pec minor muscle in the chest,
Okay.
they call that VPMS, venous pectoralis minor syndrome.
VPMS.
Got it. And, as you might guess, if you've got compression happening in both places, it's termed VTOS VPMS.
Makes sense. Now, there was another term mentioned, McCleary syndrome. What's that?
McCleary syndrome. That's a specific situation where the subclavian vein gets blocked intermittently, but there's no actual blood clot, no thrombosis.
So just temporary blockage, what causes that?
It's thought to be compression specifically between the subclavius tendon and the anterior scalene muscle.
Yeah.
And it gets worse when you lift your arm out to the side abduction.
And what does that feel like for the patient?
They might notice their arm turning a bit blue, see superficial veins swelling up, and just feel a general swelling or heaviness.
But no clot.
No clot. But even without thrombosis, it can really limit arm function and cause discomfort, so surgical decompression is often still needed for McCleary syndrome.
Okay. Now, the sources also stress distinguishing this primary VTOS from secondary subclavian axillary vein thrombosis. What's the key difference?
Yeah, that's crucial. Secondary thrombosis means the clot happens because of something else going on, some other underlying condition or factor.
Like what?
Oh, a whole range of things. Could be nephrotic syndrome, tumors in the chest, cancer in general, maybe local surgery or trauma in that area. Also, hypercoagulable states, conditions where your blood clots too easily.
Okay.
And things like kidney failure, needing dialysis, long-term central venous catheters, or even cardiac devices like pacemakers.
So secondary seems to have a more obvious external or medical cause compared to the primary anatomical activity-related type.
Generally, yes. And the most common mechanical causes for secondary clots are those central venous lines and pacemaker wires.
How common are clots with central lines? Sounds worrying.
Thankfully, it's relatively low, maybe 5% or less of lines inserted. But certain things increase the risk.
Such as?
Like if the catheter tip isn't in the right spot, if it's put in on the left side, if it has multiple lumens or channels. Also things like long-term antibiotics or IV nutrition, chemo, having cancer, or one of those hypercoagulable states we mentioned.
And do people always know they have a clot from a line? Are there symptoms?
Not always. They can be asymptomatic, which is a concern because a piece of that clot can break off and go to the lungs, a pulmonary embolism or PE. That happens in maybe 15 to 25% of these cases.
Wow. And it's not just about how long the catheter's been in.
No, duration isn't the only factor. Other risks play a big role.
And you said pacemaker wires are an increasing cause too.
Yeah, as more pacemakers are implanted. Risk factors there include having multiple leads, maybe having had a temporary pacer before, having poor heart function like an ejection fraction under 40%. Also, infection at the insertion site is a big risk factor for vein narrowing or even blockage. Anticoagulation, blood thinners, can help prevent a full clot, but they don't necessarily stop the vein from narrowing, the stenosis itself.
So the core issue in these secondary cases is often damage to the vein wall.
That's a key part of it, yes. And with catheters, sometimes when you pull the line out, this fibrin sheath, like a sleeve of clot material that formed around it, can embolize.
Break off in trouble. Okay, so we've covered what VTOS is, the types, the causes. Let's talk about how it actually shows up. What are the typical signs and symptoms?
Right. Well, the average age people get diagnosed is around 32, but we are seeing a trend towards younger folks, probably linked to sports and intense activities.
And gender. Does it affect men or women more?
You know, older reports sometimes suggested women more, but more recent, larger studies show it's pretty much an equal ratio now.
Okay. And we mentioned effort thrombosis, so activities are key.
Definitely. Strenuous or sustained upper extremity use. Athletic stuff, certain jobs, and it usually happens in the dominant arm.
Makes sense.
And here's something else. While it's not always linked, sometimes VTOS can be the very first sign that someone has an underlying hypercoagulable condition, a blood clotting disorder they didn't know about. One study found that in about 25% of VTOS patients they tested,
Wow, okay, so what's the absolute classic hallmark sign?
upper extremity edema,
Hmm.
swelling, significant swelling, often from the shoulder right down to the hand.
And what else comes with it?
Usually pain in the arm, and often a bluish discoloration cyanosis. The swelling is typically non-pitting. You press it, it doesn't leave an indent.
That bluish color?
Yeah.
Could that be confused with something else?
It can be, yeah. Sometimes it gets mistaken for cellulitis, a skin infection, which can unfortunately delay the right diagnosis and treatment.
Yikes. Okay, what other physical signs might you see?
You often see dilated superficial veins across the shoulder, chest, maybe the neck. These are collateral veins.
Like detour routes for the blood.
Exactly.
Right.
Trying to bypass the blockage. Sometimes people call it a first rib bypass.
Huh, interesting.
And a smaller group might get symptoms that feel more like neurogenic TOS numbness, tingling probably due to those muscle variations, and repetitive use affecting nerves too.
And the pain, what's that like?
It varies, but often described as aching, maybe stabbing, or just tightness in the arm and shoulder. And the key thing is it gets worse with exertion.
Why is that?
Well, when you use your arm hard, more arterial blood flows in. But if the venous drainage out is blocked or slowed, the blood backs up.
Yeah.
You get venous hypertension, congestion, and worsening symptoms.
Right. The sources had some stats on how common these symptoms are.
They did. One big study found arm swelling in 93% of patients, bluish discoloration in 77%, aching pain with exercise in 66%.
But some were asymptomatic.
Yeah, about 8% in that study. Another study had slightly different numbers. 52% symptomatic, 39% felt completely disabled by it, and again around 9% symptomatic. So there's a range.
Okay. Are there really serious complications we need to worry about with VTOS?
Well, the two big ones potentially are pulmonary embolism, the clot traveling to the lungs, and something called upper extremity phlegmasia cerulea dolens, which is a very, very rare type of venous gangrene.
How common is PE from an arm clot?
Fortunately, the reported incidence seems to be less than 10%. It's thought maybe because the total clot burden in the arm is often smaller than in the leg, the PEs might be less severe too, but still a serious concern.
And the venous gangrene.
Exceedingly rare.
Yeah.
Really only reported in the context of underlying cancer or severe clotting disorders. Not something seen just from primary VTOS itself, based on reports.
Okay, good to know. So if a doctor suspects VTOS based on history and exam, the swelling, cyanosis, pain in a young active person, what's the next step to confirm it?
Imaging. You absolutely need imaging to confirm the diagnosis.
Right.
The physical exam findings can be pretty dramatic. The swelling can sometimes make the arm look twice its normal size, and those collateral veins on the chest can be very obvious. Though in older patients, you do have to think about other things too, like lymphedema or malignancy causing similar symptoms.
What about those provocative tests like Adson's test or the East test that are sometimes used for TOS? Are they useful here?
Not really for VTOS, no. They might have some use for neurogenic TOS, the nerve kind, but they're not reliable for diagnosing the venous form.
Why not?
Well, take Adson's test where you check the pulse while moving the arm and neck. It can be positive in up to 40% of totally healthy people, so not specific enough. And the East test is more geared towards nerve issues.
Okay, so we need to actually see the veins. Duplex ultrasound seems like a common starting point.
It usually is, yeah.
Yeah.
It's non-invasive, no radiation, no kidney toxic contrast, dye. Plus, it's widely available, can often be done quickly.
But there are challenges with ultrasound in this area.
There are. The main one is the clavicle, the collarbone, sitting right on top of the subclavian vein where it passes through the outlet,
Blocks the view.
blocks the view, and prevents you from doing the standard compression test you'd do in the leg to see if the vein squishes flat, which tells you there's no clot, you just can't compress effectively under the bone or further up into the chest.
How good is it then?
Well, historically, just using the basic B-mode image, sensitivity wasn't great, maybe only 54% because of that limitation. Specificity was okay, though.
But it's improved.
Oh, definitely. Adding color flow Doppler lets you see the blood flow directly. And looking at indirect signs like how the flow pattern changes with breathing or how it responds when you squeeze the arm downstream that's boosted sensitivity way up, now often reported between 81% and 100%. Specificity remains high too.
That's much better. But still a chance of missing it, a false negative.
Yes, the false negative rate can still be up to 30%. So if the clinical picture really screams VTOS, a negative ultrasound doesn't completely rule it out. You might need to look further.
What are the key things ultrasound does show if there is a clot?
You might see no flow at all in the subclavian vein or loss of the normal wavy pattern in the axillary vein flow. Sometimes you can actually see the thrombus, the clot itself.
Okay.
And doing provocative maneuvers during the ultrasound, like having the patient move their arm out and up, can sometimes help by revealing compression that isn't there at rest. It can also help differentiate McCleary syndrome from a fixed clot.
What about other imaging like MRV or CTV, magnetic resonance or CT venography?
Yeah, those are being used more and more. They're also non-invasive, and their accuracy, sensitivity, and specificity is generally comparable to duplex ultrasound.
Any advantages to CT or MIS-R?
Well, CTV, the CT scan, can often see the central chest veins better, and depending on timing, might also pick up a PE if one is present. CTV is also pretty good at showing the mechanical obstruction itself, collateral flow, and chronic clot.
So why not just jump to CT or MIS?
Often, cost and time are factors. MRI, though, is pretty standard for suspected neurogenic TOS because it's great at showing soft tissues and where nerves might be getting pinched, and can show vessel involvement too.
And then there's traditional venography, the catheter-based one, still the gold standard.
Technically, yes, it's considered the gold standard for a definitive diagnosis, but it's invasive, uses contrast dye that can affect kidneys, and involves radiation.
So not the first choice.
Right. It's usually reserved now for cases where you're already planning an intervention like thrombolysis, or if the ultrasound results are really unclear. Plus, maybe 20% of patients can't even have it due to contrast allergy or just not being able to get IV access in the swollen arm.
So its main role is problem solving when ultrasound is iffy.
Pretty much. And when it is done, it's crucial to get images with the arm in different positions at rest, then abducted 90 degrees, maybe 180 degrees.
Why the different positions?
To confirm if there's that extrinsic compression happening dynamically. It also gives a great look at the collateral veins, which tells you how significant the blockage is hemodynamically and maybe how long it's been there. All that helps guide treatment.
Right. And based on all this, patients get sort of categorized.
Yeah, usually into acute thrombosis, chronic or recurrent thrombosis, or maybe just a high-grade symptomatic stenosis, a tight narrowing causing problems.
Okay, so we have a diagnosis. Let's shift to treatment. Sounds like this area is, well, a bit debated.
That's putting it mildly, yeah. There's definitely ongoing discussion about the optimal strategy. A big reason is the lack of large, prospective, randomized trials directly comparing different approaches head-to-head.
Why no big trials?
Well, it's challenging to design and run them, partly because experts have differing opinions on the roles of anticoagulation, clot-buzzing drugs, and surgery.
But there are efforts to gather better data. You mentioned a registry.
Yes, exactly. There's a national registry based at UC Davis, and the Society for Vascular Surgery has put out reporting standards for TOS. The goal is to collect more consistent, high-quality data on treatments and outcomes.
That's good.
Hopefully that will help us refine guidelines down the road based on solid evidence.
Okay, so historically, what about just using anticoagulation blood thinners alone?
That was often the approach. Rest, elevate the arm, put the patient on blood thinners for a variable amount of time. But looking back, the results were pretty mixed.
How so?
An early, quite influential report by Hughes found that maybe 40% of patients treated that way had persistent symptoms or didn't fully recover arm function.
Not great.
And more recent studies using quality of life scores, like the DHH questionnaire, tend to show that surgical decompression actually fixing the underlying compression often leads to better long-term function and quality of life, especially for primary VTOS.
Are there factors that make anticoagulation alone less likely to work?
It seems so. Being young, very active, being a competitive athlete, these factors seem linked to higher failure rates with just anticoagulation. The clot might come back, or symptoms persist.
What about treating those secondary clots, the ones from catheters or pacemakers? Is that approach different?
Yes, the goals there are mainly preventing PE and restoring flow. Often, just removing the catheter and giving anticoagulation for about 3 months works well.
Which anticoagulants?
DOACs, the direct oral anticoagulants, are usually preferred now over warfarin, unless maybe the patient has cancer. If the catheter has to stay in, anticoagulation continues as long as the line is needed.
What about thrombolysis for secondary clots?
It might be considered if the clot is really extensive in the axillary vein, causing major swelling. And rarely, if someone absolutely can't take blood thinners or gets a PE while on them, an SVC filter might be discussed, but that's uncommon for upper extremity clots due to filter risks and the lower rate of fatal PE compared to leg clots.
Okay, back to primary VTOS. You mentioned clot-busting drugs, thrombolysis. How does that fit in?
Catheter-directed thrombolysis, dripping the drug right onto the clot via catheter, has become a common initial strategy.
Why?
The goals are to quickly dissolve the clot, reopen the vein, and relieve those acute symptoms, like pain and swelling. And since these clots are often fairly localized, it can work really well.
How successful is it?
If you do it within about 14 days of symptoms starting, success rates in reopening the vein are reported pretty high, like 84 to 100%. After 14 days, the success rate drops off, maybe closer to 50% recanalization.
So thrombolysis helps clear the immediate blockage, but you mentioned earlier it doesn't fix the underlying squeeze.
Exactly. That's the critical thing. Lysis gets rid of the clot now, but it doesn't address the mechanical compression that caused it.
So the clot can just come back.
Big time. Rethrombosis happens in up to a third of patients within 30 days if you only do thrombolysis without fixing the compression.
Wow. What about adding angioplasty or stenting right after lysis?
Also generally not recommended before surgical decompression. Trying to balloon or stent a vein that's still being squeezed from the outside just leads to poor long-term results, reclotting, even stent fractures.
So aggressive PNS during lysis is out. Okay. What about the idea of doing lysis before surgery? Does it improve the surgery's long-term success?
That's a really interesting question, and the jury is still somewhat out. Some retrospective studies haven't shown a clear long-term patency benefit from doing thrombolysis first versus just anticoagulating and then doing surgery later.
So maybe lysis isn't always needed beforehand?
Some centers are definitely moving that way.
Yeah.
Given the risks of lysis bleeding plus the cost and resources, the thinking in some places is shifting towards maybe just starting with anticoagulation, letting the acute inflammation settle, and then going for surgical decompression.
Okay. What if thrombolysis is tried but doesn't fully work? The vein stays blocked.
If lysis isn't fully successful, then it's usually back to anticoagulation and managing symptoms. Rest, compression, elevation. Thankfully, complete failure of lysis for an acute clot is pretty rare.
When might it happen?
Maybe more likely if someone's had multiple failed lysis attempts before, especially with aggressive ballooning, or if they have very old chronic clot that was only treated with anticoagulation for a long time.
Could surgery still help even if the vein stays blocked after lysis?
Potentially, yes, in selected cases. Some small studies suggest that even with a chronic occlusion, doing the first rib resection to decompress the area might, over time with anticoagulation, allow the vein to gradually reopen somewhat.
Okay. Now, if thrombolysis is successful, the vein is open, what next?
The crucial next step is figuring out if there's still significant extrinsic compression. That means doing that positional venogram again.
Arm up, arm down.
Exactly. If there's no significant compression seen after lysis, then maybe just 3-6 months of anticoagulation is enough. No surgery needed.
But if compression is still there?
Then you definitely don't want to just balloon that narrowed spot aggressively. It can actually injure the vein lining and make things worse long-term without fixing the root cause.
And definitely no stenting without decompression first.
Absolutely contraindicated. Stents just get crushed or break in that environment. The recommendation is clear. If extrinsic compression persists after lysis, you need early surgical decompression. Then maybe address any residual stenosis with angioplasty after the compression is gone.
So it really sounds like surgical decompression is often the cornerstone of long-term treatment for primary VTOS.
For most patients with proven extrinsic compression or persistent stenosis after lysis, yes. The risk of reclotting with anticoagulation alone is just too high, and endovascular fixes alone aren't durable if the squeeze remains.
Right. The goal of surgery is to take the pressure off the vein.
Exactly. Usually involves resecting the first rib, at least partially, and often external venolysis, carefully freeing the vein from any scar tissue around it.
And the timing. You mentioned maybe doing it sooner rather than later after lysis.
Yeah, the trend seems to be moving towards earlier decompression, maybe even during the same hospital stay as lysis, to cut down that window where the vein could reclot while waiting for surgery. Some places, as we said, are even going anticoagulation first, then surgery relatively soon after, followed by a post-op venogram.
Okay. The sources mentioned different surgical approaches: paraclavicular, infraclavicular, transaxillary. Can you walk us through those briefly?
Sure. There's definitely debate among surgeons about which approach is best, and each has pros and cons regarding exposure, what structures are easily reached, and potential risks.
Let's start with paraclavicular. That's from above the collarbone.
Correct. Incision above the clavicle. The surgeon works down, might divide part of the neck muscle, sternocleidomastoid, moves the fat pad containing nerves carefully, identifies and protects the phrenic nerve.
Nerve to the diaphragm, right.
Right. Then resects the anterior and middle scaling muscles and takes out the first rib as far towards the middle and front as possible. Sometimes needs a small counter incision below the clavicle to get it all. Then they check the vein for scarring, close up, maybe do a venogram later.
Okay. What about infraclavicular, below the collarbone?
Yep. Incision below the clavicle. This usually involves taking out the front part of the first rib, releasing the subclavius tendon, dividing the scalene tendons. Because you have good access to the vein here, often a vein patch angioplasty is done, if needed, using a piece of vein from elsewhere to widen the subclavian.
Patching it open.
Yeah. For really long narrowings, might need a bigger incision across the breastbone. Sometimes angioplasty stenting is used after if patching isn't feasible, but results are mixed.
And transaxillary? Through the armpit.
Correct. Incision in the axilla. Key here is finding and protecting the intercostal brachial nerve for skin sensation. Then divide the scales, carefully dissect the first rib off its attachments, including the lung lining, and resect it. Also divide the middle scaling. Importantly, this approach usually includes a very thorough external venolysis, freeing the vein completely before closing. Some groups really prefer this approach.
So the rib gets resected, but what about the vein itself after the pressure is off? Sounds like it might still be narrowed or damaged.
That's very common, yes. Residual stenosis, even after good decompression, isn't unusual. And how best to manage that is another point of discussion.
What are the options?
Ranges from doing a venogram right then or soon after, and ballooning or maybe stenting any leftover narrowing, all the way to bigger reconstructions like taking out old clot, patching, even bypasses in rare complex cases.
But the bigger reconstructions are riskier.
Generally have higher complication rates, yeah. So the trend now is more towards using endovascular techniques, ballooning, maybe limited stenting, to fix residual stenosis after the decompression is done, either during the same surgery or within a couple of weeks.
Intra-op or early post-op venogram seems key then.
Definitely. You need to check. Intraoperative venography lets you fix it right away. Delayed also seems to work well. The current thinking is you really need to evaluate for and treat residual stenosis after decompression, using venography or maybe IVUS, intravascular ultrasound.
IVUS, ultrasound inside the vein.
Yeah. Some data suggests IVUS might actually be more sensitive than venography for spotting subtle but significant narrowings that could cause problems later.
Makes sense.
Yeah.
And after all that surgery, maybe vein treatment, what about recovery? Physical therapy must be huge.
Absolutely critical. It needs to be a specialized PT program for TOS. Focuses on scar mobilization, getting full shoulder girdle movement back, neck posture and mobility, strengthening supporting muscles like scalenes, stretching tight ones like traps and pecs, gradually getting back to functional exercises, especially shoulder elevation. It takes time, minimum 6 weeks usually, slow and steady, especially for athletes. Rushing back based just on range of motion can lead to scarring and nerve issues.
What if VTOS comes back after treatment? Recurrence.
Most likely cause is usually some residual piece of the anterior first rib left behind, or the subclavius tendon wasn't fully released, allowing continued compression.
So, inadequate initial surgery.
Often, yes. If a new clot forms early, maybe thrombolysis again, but needs anticoagulation and a workup, including x-rays, to figure out why it recurred. If it's scarring, might need a different approach like infraclavicular to repair the vein. If it's leftover rib, might need a revision surgery via supraclavicular or transaxillary.
Redo surgery sounds tough.
It is challenging. Lots of scar tissue, higher risk of injuring nerves or vessels.
Despite all these complexities, what are the overall results like? Do patients do well long-term?
Generally, yes. Most of the data comes from case series, not huge trials. But the overall picture suggests that for the right patients with primary VTOS, combining clot removal or prevention with thorough surgical decompression gives excellent and durable results. Vein stays open, symptoms improve, function returns.
That's encouraging.
And interesting, while you might see some vein narrowing with arm movement on the other, untreated side, the risk of actually getting a clot there is low. So prophylactic surgery on the asymptomatic side isn't usually done.
Unless maybe for a very high-level athlete.
Possibly. For someone needing absolutely maximal unrestricted arm function, contralateral decompression might be considered in select cases.
Okay, let's wrap up this deep dive. We've definitely covered a lot of ground on VTOS.
You certainly have. From the history and the underlying anatomy, the squeeze points, all the way through the diagnostic puzzle with imaging, and into the nuances of treatment lysis, anticoagulation, surgery.
Yeah, that theme of comprehensive management really came through. It's not just about the clot, is it? It's about addressing that root mechanical cause with decompression
Yeah.
and then carefully managing the vein afterwards.
Absolutely. It's a fascinating example of how our anatomy and our activities can sometimes conspire to cause problems in the vascular system.
So here's a final thought to leave you with.
Yeah.
We talked about how common repetitive upper body movements are in sports, in many jobs. How much difference could greater awareness make? If people recognize the early signs of VTOS, the swelling, the discoloration with activity, and knew the risk factors, could we potentially catch this earlier?
That's a really interesting question.
Could earlier diagnosis and management prevent some of the more severe complications, maybe lead to quicker, less disruptive recoveries? Something to think about.
Definitely food for thought.
Thanks for joining us for this deep dive.